is when to start continuous renal replacement therapy or renal replacement therapy, and it's a big question. I have some links of interest, and most of them with the companies that build the machine, but with all of the companies that build the machine. And more than when to start, I think that the real question is why to start renal replacement therapy. We have some absolute indication to start renal replacement therapy. You can see there that the high level of urea, hyperkalemia, hypermagnesemia, acidosis, lactic acidosis with metformin or metabolic acidosis, and also a fluid overload with a diuretic resistant fluid overload. But some of this absolute indication are debatable because probably we can treat acidosis or hyperkalemia with other therapeutics than only renal replacement therapy. And also metabolic acidosis, we have to focus on anion gap to be sure that metabolic acidosis is more due to the renal impairment than to indusable anion like lactate or acetate or other or ketosis, because in this case we cannot remove these anions with the renal replacement therapy. If we look at why most of the clinicians start renal replacement therapy, we have the absolute indications that we saw before. You can see metabolic acidosis, volume overload, hyperkalemia. But you have also some clinicians that will start with the definition of the KDIGO stage, stage 1, 2, or 3. The problem is that the KDIGO stage was not built to know when we have to start renal replacement therapy. These stages was to do research and to have an harmonization of the patient when we talk about acute kidney injury with the KDIGO stages. All the ICU clinician will talk about the same thing, but this was not built to know when we have to start renal replacement therapy. The problem is if you start renal replacement therapy only on the KDIGO stages, you will take into account only the creatinine or the diuresis. But the problem is, as you know, that the increase of creatinine is clearly late in comparison with the first injury of the kidney. And clearly, we will need more biomarkers to know exactly when the injury of the kidney occur, and probably when we will have to start renal replacement therapy if the biomarker is able to give the information if the kidney will recover or not in the next days. But we studied a lot of biomarkers like NGAL, cystatin C, or nephrocheck and others, and for the moment we didn't clearly find the holy grail. We need this, in fact, like for a pregnant test, just a test with urine, and the test will say acute kidney injury, no acute kidney injury, and the test will say, okay, you have to start renal replacement therapy or not. But for the moment, clearly we don't have these biomarkers. What do we know for the moment? First, we know that we don't have to start renal replacement therapy before acute kidney injury, despite some very specific situation. But in this study by Didier Payen, clearly the septic patient without acute kidney injury had worse outcomes than patients that have no renal replacement therapy without acute kidney injury. And clearly, if you have a sepsis or other condition, inflammation or other condition, without acute kidney injury, probably you don't have to start renal therapy. The last studies, in the last 2 to 3 years, 3 big randomized control studies. 2 negative studies when the randomization occur when the patients reach the stage 3 of Cadigo stages, and the 2 studies was negative. If you start renal replacement therapy early or late, the mortality was the same. And 1 study was positive when the randomization occurred at stage 2. But the problem is, in this study, most of the patients have fluid overload and were patients from cardiac surgery. And clearly, the indication for renal replacement therapy due to fluid overload was good in early to remove a lot amount of water. And the last study, the biggest one with more than 2,000 patients included, also didn't show a difference in terms of mortality between early start of renal replacement therapy at stage 2, 3 of Cadigo, or a start of renal replacement therapy due to absolute indication. But the problem with all these studies are the condition for randomization, and the need for renal replacement therapy was only based on the Cadigo stages. And clearly is probably not the good focus, the good marker to know if we have to start or not renal replacement therapy. And the problem is, clearly you have no difference in terms of mortality. And probably you harm some patients if you start too early renal replacement therapy. But if you start too late with a delay strategy too late, clearly the outcome of this patient are worse. It's true in this study, ITT study, and it's true also in this study. And probably you harm some patients to start too early, but you harm some patients also to start too late. And the first paradigm 10 or 20 years ago was we have to start early renal replacement therapy. And as usual in medicine, when you have a paradigm and you have new research, new knowledge, you switch from one paradigm to another. And the problem is, most of the time, the pendulum is going too far in one or the other position. And in the last 1 or 2 years, the pendulum is going more to the late position, and probably now too far to the late position. And practitioners are prone to use renal replacement therapy more and more later, and the best timing probably is between early and late, but we have to find the good marker to know when we have to start and why we have to start renal replacement therapy. And perhaps this diagram by Schoenbach-Shaw in 2009 was good. You can see the absolute indication. Yes, you have to start renal replacement therapy. If you have an AKI present, you have to decrease the hemodynamic parameters and all the parameters of the patient. After, you have to see the AKI stages, and probably we have to change there. For AKI 1, we don't have to think about renal replacement therapy, just we have to reassess the clinical status. And for 2 and 3, probably we have not to consider initiating renal replacement therapy directly. We have to wait a bit, see other factors, the rapidity of worsening AKI, other factors of sepsis, hypercatabolic state, and other, and perhaps at this time with these factors, think to start renal replacement therapy. Thank you for your attention.
Thank you, Olivier.